A patient presents with the sudden onset of unilateral facial drooping. This triggers an immediate clinical question. Is this an ischemic stroke or Bell's palsy? Patient A retains deep furrows on both sides of the forehead. Patient B's forehead is smooth on the affected side. This distinguishes central from peripheral weakness. For patient A, paralysis is limited to the lower face. For patient B, the entire side is involved. The facial nerve functions as a specialized conduit for more than just muscle contraction. Cranial nerve 7 carries a diverse anatomical payload: branchial motor signals for expression, parasympathetic instructions for glands, and special sensory fibers for taste. By systematically testing voluntary movements, involuntary reflexes, and autonomic functions, a clinician can map the exact topographical site of a lesion anywhere from the cerebral cortex to the peripheral nerve endpoints. The origin point for facial motor control is the facial nucleus, located deep within the pons of the brainstem. This nucleus is divided into two distinct segments, one controlling the upper face and another for the lower half. The segment innervating the lower face receives motor signals strictly from the contralateral side of the brain. Conversely, the upper face segment receives redundant motor signals from both the left and right hemispheres of the brain. During a stroke in one hemisphere, the lower segment loses its only source of input. However, the upper segment continues to receive signals from the healthy, opposite side of the brain. A peripheral lesion occurring after these signals have combined, as the nerve is exiting the pons, cuts off all pathways to both the upper and lower face simultaneously. Because of this dual innervation, a spared forehead confirms a central brain lesion, while a paralyzed forehead dictates a peripheral nerve problem. In some cases, central facial weakness only appears under specific clinical circumstances. This patient fails to voluntarily show her teeth, but presents a perfectly symmetrical smile to a joke. Voluntary movement is the exclusive responsibility of the primary motor cortex. The CT scan confirms the infarct is limited to these superficial cortical structures. The opposite can also occur. Here, voluntary movements are intact, but the spontaneous emotional expression in panel B is asymmetrical. Involuntary mimetic expressions are driven by entirely separate, deep subcortical structures, including the striatum, globus pallidus, and hypothalamus. The MRI in panel C correlates this dissociation to a deep-seated right hemispheric infarct, sparing the motor cortex. By comparing a requested grimace to a spontaneous laugh, a clinician can differentiate a surface cortical stroke from a deep brain infarction. In peripheral cases, we track the facial nerve as it exits the pons and enters the internal auditory meatus. The first major branch point is at the labyrinthine segment, where the greater superficial petrosal nerve splits off from the geniculate ganglion. Because this branch controls the lacrimal gland, a lack of tear production localizes the lesion to this specific junction. Further along the mastoid segment, a separate branch innervates the stapedius muscle. If everyday sounds feel painfully loud, the stapedius is no longer dampening vibrations. This hyperacusis means the lesion must be proximal to this branch. The third checkpoint is the chorda tympani, which carries special sensory and parasympathetic fibers. Damage here results in a loss of taste on the anterior 2/3 of the tongue and reduced submandibular salivation. Finally, at the stylomastoid foramen, the nerve exits the skull. A lesion here produces pure motor weakness without affecting tears, hearing, or taste. Cross-referencing these autonomic and sensory symptoms allows the clinician to locate the exact millimeter of nerve damage. Most peripheral cases without an obvious external cause are diagnosed as idiopathic Bell's palsy, accounting for up to 75% of unilateral facial paralysis. Virologic evidence links these cases to herpes simplex virus type 1 reactivation within the geniculate ganglion. As the virus triggers a cascade of inflammation, the facial nerve swells tightly within the rigid, unyielding bone of the facial canal. This restricted space creates a mechanical conduction block that chokes off nerve signals. On MRI, this inflammation appears as brightness, or contrast enhancement, in the geniculate ganglion and the tympanic segments of the nerve. This local inflammation in panel A stands in stark contrast to the central pontine infarct shown in panel B. Bell's palsy represents an acute mechanical compartment syndrome within the skull, triggered by viral reactivation. Spontaneous recovery occurs in over 70% of patients, but the remaining percentage faces permanent facial weakness. Severity is measured through electroneurography, which records the amplitude of the facial muscle's action potentials. Electrical testing reveals no change during days 1 through 3, as physical axonal degeneration is delayed following the initial compression. However, if nerve excitability drops by 90% between days 4 and 10, the chances of a full recovery are drastically reduced. To prevent this, clinicians administer high-dose corticosteroids within the first 2 weeks to reduce canal swelling. Antiviral medications are often added to the regimen to address the underlying viral infection. If medical management is insufficient, surgical decompression of the nerve may be considered, though it is physiologically futile after 14 days. The neurological physical exam maps the structural reality of the nerve, identifying the narrow temporal window required to save a patient's expression.